Why is it important? It improves patient satisfaction with care. It improves the quality of life for people. We have less unwanted medical care that aligns with wishes, so if you don't have the communication, we're not going to be able to do that. It also puts less stress on the person that has to make decisions when it's the most difficult for the surrogate, for the healthcare agent, for the backup person, when the person is incapacitated and unable to speak for themselves. It's not easy from a personal perspective. Individuals and families don't want to talk about death. It's important having these conversations to identify these things. Many people, from a perspective of an individual, don't see the importance of it. Our lack of awareness during the time of COVID has come to the forefront more than ever. That understanding becomes more significant. The condition can change at any given time. Often, there are unclear treatment options and decisions, and we need to pull that to the forefront. We also don't want to have to deal with it, but often there's family conflict. One family member may say to another family member, "I don't agree with this," or they might be arguing right in front of the person, not recognizing it's from the person's spectra. A big one is that they don't designate a healthcare agent by default. Our standard of carers do everything by default. We follow our centric hold with next of kin of who it is that we'll be talking to that may not be on the same page. The earlier we have this conversation, the better it is, the who's and the what's of what we need to do. With the whole delivery of patient-centered care, we really want to focus on that it's not just disease. From a perspective of a healthcare provider, we have multiple transitions that happen. There are times that we don't need to be having people come in the hospital, even during COVID. What are their options? What are the things that are out there so that getting palliative care is delayed? We have to have that access sooner. There becomes more demand for the family to take care of these people, managing the households, all the other different things, which becomes a burden. These are things that can be avoidable, which is very nice. The Institute for Healthcare Improvements says there are key steps we need to do to find out what's going on. Check their history, conduct the 4M screening with the different things we're talking about. What are some daily prevention and maintenance managements that we can do? What if it changes the condition? What are we going to do? Plan A, Plan B, and so forth. Work from there. The same type of thing would be from a hospital perspective that you would do in primary care. You would co-create a goal-oriented care aligned with what matters. Really focus back to the person's priorities, not just from a medical perspective on disease. Ask, what do you want me to focus on while you're with me under our healthcare team? Focus on what matters to them, not here's what I'm going to do. There's so many people who will request do everything, or we don't know. That's why we have to go back to the perspective of goals, wishes, and what matters. If you have somebody that's advanced or serious, ask, what are your most important goals? Especially if their health situation were to worsen. Plant the seed that things may change. There's a different perspective of hope that will come up, but don't string them along that everything's going to be back to normal, because that's not a good way to go either. One of the things we have is what's called POLST, which stands for Physician's Order for Life-Sustaining Treatment. It's a portable voluntary medical order. It's very nice because it's signed by the patient or their agent if they're not able to sign for themselves, and put into order by a physician or advanced practice provider. It is portable from one setting to another. The philosophy, nationally, is that individuals have their right to make their own healthcare decisions. The rights should be based on decisions about life-sustaining treatment, describing these things, and receiving comfort along the way. Comfort should always be provided as care. Comfort care does not mean do not treat, do not resuscitate, or any of those type of things. All of us want to be kept comfortable, no matter where we are. It's very important. We have our honoring choices. North Dakota has a North Dakota POLST. This is our North Dakota POLST form. There's a whole conversation and documentation guide so that it will help the person understand where it is and what we have. It separates out CPR from any other kind of medical treatment For example, resuscitation. Do we allow natural death or do we attempt because we can't guarantee it? It's totally separate from how much aggressive medical treatment somebody wants, from comfort measures only to limited or full treatment. There's a section on nutrition. How far and how much somebody would want the documentation part includes where we are, with whom we talked to, or what did we refer to. We have them sign it along with the attestation from the patient. On the second page, we have who was the healthcare agent that prepared the form. It doesn't necessarily have to be the person that is putting it into order. It's similar to somebody doing an informed consent for surgery. Somebody else may have discussed it for them or other treatment options. Someone else may have had a discussion with them, but this is a double check since it's life or death. Before somebody signs that these things are in place, the directions for it are on the back. We have a whole CME available on our website for more education and scripting and how to talk about this more. We encourage you to be looking into utilizing a pulse for people that are seriously ill or nearing the end of life, the last 1 to 2 years of somebody's life. They complement each other. There's also an advanced care directive. Those conversations should complement one another, but they're used in different way. How to have further conversations doesn't stop here. It should be lifelong. It should be getting from the time of somebody who's only 18 years old and moving forward from there. Engage the whole team, the nurses, social workers, and chaplains with this conversation. We can do little bits and pieces before we have it complete, and it may change and transition over time depending on healthcare conditions. Staff are trained specifically with having facilitated conversations. I encourage using those we have in our state, called Honoring Choices North Dakota. It's a collaborative throughout all the different agencies, disciplines, and institutions throughout the entire state. It helps with having goals towards advanced care planning conversations and honoring people's wishes, thus honoring choices. This is our Honoring Choices North Dakota website. If you type in Honoring Choices ND, you'll probably find us. We have a section specifically regarding healthcare directives and resources. You can also find some of our upcoming events. There is a specific tab at the top for Pulsed, and that's where you can find the CME. There's how to do facilitator training, some healthcare directives, including how to do a notary online and other resources. This is the Stanford Letter Project website. This is a tool that you give to the patients before they see the doctor about what matters. You're planting the seed for some of the conversation that may occur. They include the templates for that, as well as the bucket list. The What Matters letters are very valuable for moving forward in that direction. One of the 5 steps of Prepare is to decide what matters most in life. It's not just the who, but the what and how to tell people about that. Also, have the right questions to ask your doctor. Prepare helps the skills to identify how to talk to families and friends, how to make informed decisions, and getting the care that's right for them. It was created with many different people from different age groups. They have actual videos that can model how to have advanced care planning conversations. Sometimes that visual along with auditory makes a big difference. They talk about how to make a decision about the decision maker and some of the preferences. You can also create a medical plan. Make a list of your medications and what to bring to the hospital. Do not forget them at home. Think of it as being just as important as other documents that you might want to keep a copy in your glove compartment. There's even a My Directives on an app, or you can put it on a jump drive and carry it around for you. These are things to be considering. The Conversation Project. They have starter kits from the black, white, or the gray zone. This is translated into many different languages. It teaches how to talk to your doctor and what kind of questions we should ask. Medicine is consumer-based. It is monetarily based. As consumers, we should be able to have choices and have things explained in a way that is understandable. There's also how to make a decision on your healthcare agent, how to talk to people that lack mental capacity or have dementia, and there's a whole section on pediatrics. There's a really broad range. This is our pulsed information sheet for families. It explains what it is, why is it important, and how do you get one. This is a list of all the different references. Take some time to get more familiar with these resources. We hope that this has been helpful for you. Thank you for listening to this presentation.